The other persons, please. So, good evening and welcome back to this second part of nerve conduction studies and EMG. And the speaker is Dr. Radhika Manohar. We have already listened to her in the first talk previously, and she will continue with more cases today. The session will be approximately 1 hour, and she will try to cover as many cases as possible. Dr. Radhika, please take over.
Thank you. I hope I'm audible to everyone.
Yes.
Okay, carry on. So welcome back to part 2. So in part 1, we looked through nerve conduction studies. This time we'll be focusing on EMG and conditions that depend on EMG for diagnosis. So what we'll do today is how to approach EMG. So that's just a very brief introduction as to you've done your nerve conduction studies, you have your clinical information. Now, how do you plan your EMG study? We'll then quickly go through abnormal EMG changes, for example, abnormal spontaneous activity, as well as motor unit action potentials, looking at neurogenic potentials and myopathic potentials. We'll then just look at the evaluation of 3 different disorders where EMG is the most definitive or the most important test, namely radiculopathy or root disorders, motor neuron disease, and myopathy. So if you've attended the last lecture, you'll remember postganglionic and preganglionic. Postganglionic is anything distal from the dorsal root ganglion all the way to the sensory nerves, sensory afferents. So that will include your peripheral nerve, plexus, as well as dorsal root ganglion. That's postganglionic. Preganglionic is anything proximal. That will include your roots, which is dorsal or ventral root, as well as the motor neuron here, or the anterior horn cell. You will also have a reasonable idea after your clinical data as well as the nerve conduction study whether you might be possibly looking at a neuromuscular junction disorder or a muscle disorder where it's distal. So it's not typically pre or post ganglionic, but definitely the nerve conduction studies will give you a clue as to what it might be. So for example, if it's post ganglionic, your sensory responses will be abnormal. Pre-ganglionic sensory responses in the area of affected area will be normal. And if it's distal, as in the neuromuscular junction or muscle also, you would expect the sensory responses to be normal, unless obviously there is something coexistent, some other pathology that is affecting the sensory nerve separately, coexistent. Finally, if everything is normal, one other possibility you might be thinking is, could this be functional? There's nothing wrong with the patient. Or could this actually be an upper motor neuron lesion, since what we focus on is the motor unit and the lower motor neuron conditions. So, as I said before, after assessing the patient, the clinical data, and the nerve conduction studies figures and the numbers, you'll have a differential diagnosis. For example, a patient who has sensory symptoms in the ulnar distribution or medial 2 fingers of the hand, you will then have the nerve conduction studies with you. You will know whether the sensory responses are normal or abnormal. If it's abnormal, then you're probably looking at an ulnar neuropathy or something post-ganglionic. Or if it is normal, then you might be looking at something more sort of proximal, preganglionic at the level of root, especially since the patient also has sensory symptoms. So that's just an example. Once you've got your differential diagnosis, you then need to plan the EMG. So you're thinking this could be an ulnar neuropathy versus C8 radiculopathy versus lower trunk of brachial plexus. So you need to organize your EMG. Which muscles would you be testing? So you need to test C8 innervated muscles by other nerves, for example, radial C8 innervated muscles, median C8 innervated muscles, to prove that there is no C8 involvement, no proximal involvement, and everything is just the ulnar neuropathy. So that depends on what the nerve conduction studies show you, and obviously your clinical information. Once you have selected the appropriate muscles, you then start examining the muscles. We'll go through that in detail anyway. So when we examine the muscles, we first need to see whether the pathology within the muscle is neurogenic or it's myopathic, because that's going to give you more information as to what type of pathology or what type of condition you're dealing with. Once we have decided whether one particular muscle is neurogenic or it's active denervation or it's myopathic with myonecrosis or without myonecrosis, we then decide whether other muscles are involved. So we look at the distribution of muscle involvement. Is it symmetrical? Is it asymmetrical? And how does it localize? Is it all everything in C8 distribution, or is it everything in L5 root distribution, or is everything in upper trunk brachial plexus distribution? So that's how you work your way up. Finally, etiology. So mostly EMG and nerve conduction studies are not great for etiology. For that, you have to go back to the history. But Sometimes when you have somebody who comes with very sensory symptoms which are very acute, and you find florid fibrillations and positive sharp waves, one clue to the etiology with axonal pathology, one possibility could be that it's a vasculitic neuropathy, for example, or that it is an ischemic neuropathy. So there are tiny little clues here and there, but that's not a constant, and that's really not what the nerve conduction studies and EMG help you to do. So let's look at abnormal EMG. So in an abnormal EMG, there is something called spontaneous activity, which we need to know how to assess. And then there are the motor unit action potentials as well. And once a patient starts contracting the muscle, what type of motor unit action potentials we see, what type of recruitment, what type of interference patterns that we see. And those are the two sections we'll be looking at when we look at abnormal EMG. So abnormal spontaneous activity is any pathological activity that you record from the muscle with the needle in the muscle, which lasts more than 3 seconds on the screen. So anything less than 3 seconds, we label it as insertional activity, which is also spontaneous activity, which is also recorded from the muscle at rest, but it is not consistent. It just comes briefly, and I'll show you a video of it, and just goes immediately. So that's not really pathological. So that's normal. It's very, very important that you assess this activity with the muscle completely at rest. So a lot of people I've seen when they come to the lab to watch us do it, they think that when the patient is contracting, they think those are abnormal spontaneous activity potentials like fibrillations and positive sharp waves, but that's not correct. The hand or the limb, whichever that you're testing with where the muscle is, must be completely at rest. And that can be quite difficult. As you know, patients are very nervous when they come to a lab. So that's quite important to assure that your muscle is at rest, and what you are seeing as voluntary motor unit activity is voluntary motor unit activity and not abnormal spontaneous activity. You mustn't misinterpret that. You view the screen at about 50 or 100 microvolts. That's a sensitivity. 50, 100 is good. Keep it at 100 microvolts with a 10 millisecond division, 10 milliseconds per division. Mostly when you put the needle in, if the muscle is abnormal, you will be able to pick up the spontaneous activity, but sometimes you might need to provoke it by asking the patient initially to contract and then to relax, so voluntary activity, or asking the patient or moving the needle slightly, maybe slightly tapping the muscle next to the needle, and sometimes electrical stimulation. But to be honest, we've never needed electrical stimulation. All the other methods will be more than sufficient to show you your abnormal spontaneous activity. Now, there is also the sort of concept, shouldn't really call it, but a concept of normal spontaneous activity. So there is spontaneous activity, which could be pathological, which is abnormal spontaneous activity, or there could be normal, so-called normal spontaneous activity, which are MEP here stands for motor end plate noise or motor end plate spikes, as well as insertional activity. So I mentioned insertional activity before, as well as motor end plate noise and spikes. Now, motor end plate spikes are generated from the terminal motor axons, while the motor end plate noise actually are generated from the neuromuscular junction. These, when you see them, are not pathological. So it's important to differentiate these from fibrillations and positive waves, because end plate spikes can look a little bit like fibrillations. The other thing that is actually normal is the insertional activity, and then the rest of it will be abnormal spontaneous activity. So abnormal spontaneous activity could be generated from the motor neuron or the axons, motor axons, and you have multiple different types of activities, which we'll look at later, or they could come from the muscle fiber itself. So they could come from individual muscle fibers like fibrillations, positive sharp waves, or myotonia, or they could be generated by multiple muscle fibers, resulting in a particular discharge called a complex repetitive discharge. So these are the so-called generators of these potentials. So this is an example of an insertional activity. So you can see that brief sound, isn't it? It doesn't really last. So when it comes up on screen, it's less than 3 seconds by definition, and it's very brief, and you can't really be sure whether it's because the needle has been moved slightly, but definitely it's not pathological. So we then come to the next type of so-called normal spontaneous activity, which is a motor end plate activity, either motor end plate spikes or motor end plate noise. Both of them you'll see. So The reason why we see this normal phenomenon in a resting muscle is because our needle is actually over the motor end plate. It's not a mistake, but because we aim for the bulk of the muscle, and the bulk of the muscle is where the motor end plate is anyway. That's where you record your CMAP from. So you put the needle in the bulk of the muscle, and you might accidentally be just over, that's your recording electrode, needle electrode. You might be just in at or just over the end plate. And then at that point, whatever potentials come up are negative. So in neurophysiology, I remember, I think we mentioned that last time, but in neurophysiology, negative is upwards and positive is downwards. So any potential that comes from there is upwards is negative, like this. So these are motor end plate spikes. So when you record it from directly above the motor end plate, your first deflection is a negative deflection. Then it's a positive deflection as the potential moves away. When the potential moves away from your recording needle, the needle records it as positive. When the potential moves towards, also it's positive. When the potential is directly under the recording electrode, then it's negative. So these are motor end plate spikes. So they come from terminal axons. They are biphasic because you get, you can see the upward negative first there and then downward. So downward positive. So it's biphasic. They're negative up, positive next, and they give you a sort of sputtering sound, which we'll hear in a second. The next type of spontaneous activity that you see is motor end plate noise, which is actually monophasic. It comes from the neuromuscular junctions, and they are what is characteristically called a sort of seashell sound. So motor end plate noise from the NMJ or neuromuscular junction, they're monophasic because they're all negative upwards. There's nothing positive there. And they sound like a zh, like that, like a seashell sound, you know, like listening to a seashell. Zh, that's how it sounds like. These are all normal potentials. Another important thing is when your needle is in the motor end plate, it's extremely painful. I'm sure you remember that. You just need to move the needle away before the patient starts to scream and prevents you from doing the rest of your examination. So before I start the video, I just want to show you the screen here. That's actually an end plate spike at the start. So you can see the negative going up and then the positive. So in this video, at first you'll see a lot of sort of movement of the needle. And then you'll see these spikes, motor end plate spikes, coming like a sputtering sound, like a sputtering sound. And then after that, you'll see the actual abnormal spontaneous activity in the form of positive waves, positive sharp waves. So those are your spikes. Those are end plate spikes. And those are your positive sharp waves. So just play that again. Just listen to the one in the center. And now the abnormal spontaneous activity comes through. So those three different things, insertional activity, motor end plate spikes, and motor end plate noise, these are your normal spontaneous activity. Abnormal spontaneous activity now is fibrillations, positive sharp waves, and myotonia that comes from your muscles, single muscle fiber action potentials. Multiple muscle fiber action potentials give rise to complex repetitive discharges, and you'll have your terminal motor, your motor axons as well as motor neurons giving you the rest of the abnormal spontaneous activity. So coming to fibrillations. Now, fibrillation is abnormal. It comes because there is damage either to the muscle fiber itself, as in part of a myopathic process, because you can see fibrillations and myopathies as well as neurogenic disorders, or because the muscle fiber has lost its innervation because of a neurogenic problem, and it has become a so-called orphan muscle fiber, at which point it gives out fibrillations on its own. It has its own pacemaker, which gives out these potentials called fibrillations and positive sharp waves. So what happens in a fibrillation, and why does it look the way it is? So you have your needle here. You're recording a needle from the muscle here, muscle fiber here. This is where the fibrillation is generated from a single muscle fiber. So it's a single muscle fiber action potential. It starts moving towards your needle. And as it moves towards, remember what I said about the positive, around the fibrillation potential, it's negative, but ahead and behind, it's positive over the muscle membrane. And that's how it is normally. So as the potential starts moving towards the needle, first the needle records positive. So you get a positive deflection here. Then as the potential goes under the needle here, you get a negative deflection. And then as the potential passes your needle and goes away, you get a positive again. So that's why you get a positive, negative, and a positive. So this is what it looks like. So you got a positive as it's approaching your needle, negative when it's right under the needle, and positive as it passes the needle. And here you've lost the third sort of phase, where it's become more biphasic rather than triphasic. So sometimes that happens as well. So you got a fibrillation that starts off as positive and then negative, and then it goes on like that. And there you can see, although morphologically, immediately when you look at it, it looks like a motor end plate spike. The motor end plate spike is negative up first, while a fibrillation is positive down first. So that's a picture of a fibrillation there, mostly a triphasic type of fibrillation, positive sharp waves along with it. So they actually arise from single muscle fiber action potentials. They arise from muscle fibers because of spontaneous depolarization, either due to the damage to the muscle fiber itself or due to a lack of innervation of the muscle fiber, which makes it almost like an orphan muscle fiber without any signals coming from its nerves, and hence it starts spontaneously discharging these potentials. They could be biphasic or triphasic. Initial positivity differentiates it from end plate spikes, regular firing, and it sounds very high frequency sound. And you can see it in neurogenic disorders when there is active denervation. And you can also see it in myopathies where there is either a dystrophic process where the muscle fiber is being destroyed, or either due to an inherited process, or the muscle fiber is being destroyed due to an acquired process where, for example, in inflammatory myopathy like polymyositis, necrotizing myositis, that sort of thing. Occasionally, you do see fibrillations of positive waves in presynaptic neuromuscular junction disorders such as botulism, because of what happens. It's called chemical denervation. The denervation in botulism is so severe that it almost acts like a neurogenic denervation. But that's really rare. Botulism itself is quite rare. Where you're really going to see it is in your neurogenic disorders, much more common, because neurogenic disorders anyway are more common than myopathic disorders in any lab anyway. But you can also see it in myositis or any myopathic disorders where there are dystrophic changes or there are active polymyositis, myositic changes. So this video, you can see the positive sharp waves here already, and these are the fibrillations. You can see the positive first and then negative up. The sound is very high frequency, it's very tinny, rain on a tin roof. Those are the words that are usually used to describe these things. Okay, so, yeah.
EMG sound is not very audible.
Not very loud.
Is it possible to adjust that?
Yeah, just bring it up a little bit.
Okay, 1 second.
I think that's the highest. So that's like rain on the tin roof. So along with fibrillations, you also see positive sharp waves. They usually come together. They have the same significance. And the difference in positive sharp waves is you lose the negative deflection upwards. So it's just a positive sharp wave, and it is recorded from the muscle fiber, which your needle has actually pushed down. So when you're recording the muscle from the muscle and the needle has pushed a muscle fiber down, you actually almost get like a block. So you have a potential that is generated. It's coming towards your needle. And so you record the first positive downward deflection as you did for your fibrillation, but then you don't get the negative deflection because it almost blocks out after that. It doesn't cross your needle after that. And hence you just have a positive sharp wave looking like that. So it's positive downwards and it loses its negative component because it's blocked by the needle that you are using to record. So these are positive sharp waves, and you do see fibrillations of positive sharp waves in neurogenic disorders as well as myopathic disorders, but almost always positive sharp waves tend to be seen a little bit more commonly somehow, especially in the early denervation. There's no real evidence behind this, but this is something that we observe. So in most cases, you'll see positive sharp waves fairly quickly developing, and then the fibrillations come through. we don't know why that is, whether there's any significance to it clinically also, we really don't know. So again, same thing, spontaneous depolarization of muscle fibers. It's coming from a muscle fiber itself, single muscle fiber action potential, and it's positive downwards, regular firing, and it's a lower frequency sound as opposed to the fibrillation, which is a little bit more higher frequency. Same significance, active denervation, that is neurogenic disorders with active denervation, myopathy, myositis, that is inflammatory myopathy, as well as muscular dystrophies, and botulism, as I mentioned before with the fibrillation. So this is a very brief video, just a few seconds, but just to show you that sort of regular firing of the positive sharp wave. You can see the sharp wave there here. So that's a lower frequency than what you heard with the fibrillation, and it's a ta-ta-ta-ta-ta-ta. Once more. So we grade them. So once we start seeing fibrillations of positive sharp waves, we grade them. How we do it is by putting the needle in the muscle. We don't pull the needle out of the entire skin, leave the needle in, pull, and first record from one side, almost like an imaginary quadrant in the muscle here. And then you sort of pull it out a little bit, move it a little, and then record from another point, pull it out a bit, record from the next point, and again, and 4 points. So we're supposed to really record from 4 different points in a sort of imaginary quadrant inside the muscle in a tiny area. So don't take it out of the skin. There should be only one skin puncture. The gradation is like this. So when you say +1, it's 2 areas. So you see in just one area, like a scattered, we tend to ignore, we don't pay too much attention to it. But if you see it in 2 areas, it becomes +1. In 3 areas or more, +2, but a little bit more patchy. In +3, you see it in multiple different areas. And +4, what happens is that you really don't see any normal baseline. It's like this example here, completely filled with potentials. So these are all positive sharp waves with over superimposed with some. So there's a fibrillation there, there's a positive sharp wave, fib here, positive sharp wave. So this is completely like a profuse, full interference pattern of fibrillations and positive sharp waves, what we refer to as florid. So that's 4+. Now, what is the significance of grading? So there is some evidence that the severity is associated with the gradation. So for example, if you see 4+ in one muscle and it's about 1+ in the other, then that first muscle is more pathologically affected than the next muscle. So there is some severity. It also depends, the severity depends on the condition that you're looking at. So things like radiculopathy, peripheral nerve issues, there you can depend on the severity of the denervation to guide you as to the most affected muscle. But sometimes, but in GBS, for example, acute neuropathies like that, the persistent denervation that you see even after 4 weeks is not really it doesn't really mean that that the patient is ongoing, the GBS is ongoing. It just means that the patient has been affected so badly, the axonal loss is so bad that there is still persistent active denervation and the muscle fibers are still not reinnervated. That's all it means. It doesn't mean that, oh, it's active, so the GBS is continuing to go beyond 4 weeks and we need to treat. So we just need to make that sort of distinction. Now, fibrillations are positive sharp waves because since these are the things that really tell us and help us make a diagnosis, if we didn't have these things called fibrillations, positive sharp waves, electrophysiology would not exist. We would not know how to localize lesions properly. We would not know which muscles are pathologically affected, which muscles aren't. So it's important to know when these actually start. So fibrillations and positive waves start. The earliest recording is about 7 days, but that's really an outlier. 10 days, maybe you might get a few positive sharp waves at that point, but ideally 2 weeks. If you don't get any fibrillations or positive sharp waves, when you're sampling a muscle, 10 days after onset of symptoms, it doesn't mean it's not there. It just means that it takes a little bit longer to appear. But at 3, maximum 4 weeks, if it hasn't appeared, then it's likely that they are not there. The denervation isn't bad enough to cause such level of fibrillations and positive sharp waves. So onset of spontaneous activity, we generally tell everybody 2 to 3 weeks. You can try your luck at about 10 days, but if it's negative, it really doesn't mean anything. This picture here is an EMG of the abductor pollicis brevis. So you put the needle in and you just gently look at 4 quadrants, by sort of not taking it out from the skin, but just sort of moving it gently in 4 directions. So going to the next abdominal spontaneous activity that we see is myotonia. Myotonia comes along with fibrillations, positive shock from the muscle fiber. Myotonic discharges are much rarer in the lab. What you're going to see very often, probably on a daily basis, would be your fibrillations and positive sharp waves. Myotonia, complex repetitive discharges, these are much rarer. So these are spontaneous discharges of the muscle fiber. And it's about 50 to 150 hertz, 20 to 150 hertz is also fine. And it lasts about 500 milliseconds. It's a waxing, it has a waxing waning quality. You'll hear it in the video. It's like a dive bomber quality. Some people call it a motorcycle racing, you know, like a acceleration of a motorcycle kind of quality. And you see it, we all know we see myotonia in myopathic disorder. So that's a given. Myotonic myopathic disorders, we see it most commonly in myotonic dystrophy, for example, but you also do see it in chronic neurogenic disorders. The only difference is that you don't see such widespread myotonic discharges in chronic neurogenic pathologies, like chronic radiculopathies, for example, most commonly, but you don't see it as widespread as you would in a myotonic dystrophy. So most commonly, myotonia is in myotonic dystrophy, and it's usually so profuse, the myotonia, that you're sometimes not able to see the muscles, sorry, the motor potentials. You're not able to see the motor unit action potentials. You put the needle in, it keeps on going, and you really, the patient tries to contract, but all contraction, all the potentials that you are supposed to see when the patient contracts a muscle is completely swarmed by the myotonia that keeps going. And something quite interesting in the sense that, so myotonic dystrophy, the type 1, the most common one, you'll see the myotonia everywhere, but distal more prominent than the proximal muscles. In myotonic dystrophy 2 or proximal myotonia, you see it quite proximally, like trapezius, for example, and in paraspinals and deltoid much more commonly. And interestingly, the myotonic discharge that you record is slightly different. It's more like it has a waning quality in prom. So that means myotonic dystrophy type 2. So it goes like a while the myotonic dystrophy 1 goes so there's a slight difference. There's a waning quality to myotonic dystrophy 2. And obviously, you also see it in non-dystrophic myopathies like myotonia congenita and paramyotonia congenita, where you will be able to see the motor units a little bit better than a myotonic dystrophy type 1. You can also see it in acid maltase deficiency, particularly in the paraspinal muscles. And this is what it looks like when you draw a picture, see a picture online. So one more thing I didn't say. So when you first put a needle in, you're going to be looking at 10 millisecond division, isn't it? So each division lasts 10 milliseconds, and you're looking at maybe 200 microvolt sensitivity. So you will not see it as a typical myotonic discharge. You just hear weird sounds, and you think, okay, there's something going on here. When you are in doubt and you're wondering, could this be a myotonia or a myokymia, something going on here, you need to compress the screen so that you can get larger amounts of the screen there. So from 10 millisecond per division, you can make it maybe 0.1 second per division or 50 milliseconds per division, just so you can compress the discharges so that you can see the waxing and waning quality. So I'll show you here. So what you saw me do at the last bit, so the first one was at 50 milliseconds per division. So we had squashed it to 50 milliseconds per division. So you could see that in full glory, you could see that typical MD1 kind of myotonic discharge. But then towards the end, I wanted to look at the voluntary activity. I want to look at the motor unit action potentials, and I can't look at that if it's at 50 milliseconds per division, because we are trained to look at it when it's at 10 milliseconds per division. So then you suddenly see me change the time basis, or my technician was quickly changing the time base so that you can actually see the contraction. So we just play that one more time before we go for the next one. So I'm changing it to see the motor units. Okay. So we then come to the next one. This is also next to abnormal spontaneous activity. This also comes from muscle fibers, but they come from multiple muscle fibers. It's complex repetitive discharges. They sound similar to myotonic discharges, hence they've got this name called pseudomyotonic discharges, and they sound like a drrr, drrr. So they start very abruptly and stop very abruptly. So like some people call it jackhammer. So drrr. See that. So they group muscle fibers and they appear from multiple muscle fibers when muscle fibers are damaged either due to a neurogenic process or myopathic process. They can be seen in both neurogenic and myopathic. But one important thing is they're seen when it's chronic. They're seen in chronic conditions. So they're seen in chronic neurogenic processes and they're seen in chronic myopathic processes. So then these muscle fibers are damaged and then next to each other. So they keep sort of discharging around in a circle called apoptic transmission. And that's why multiple muscle fibers are involved in complex repetitive discharges. So starts and stops abruptly, like I said before, jackhammer quality. So they say, drrr, drrr, that's how it goes. So I've said that neurogenic and myopathic disorders, and they just like, they look the same. So although they go around and round in circles from different muscle fibers, but the same types of muscle fibers are generating it. So you see the same type of motor unit action potential on screen. So that's what it looks like. Okay, play that one more time. So the first one is just a needle moving, and the second is you can hear it. It's like, and then it stops. Okay, so those are complex repetitive discharges. You see them in chronic neuropathic processes. You see them in chronic myopathic processes. You see them much more often in chronic neurogenic processes, especially in root radiculopathies. You don't see them so much in motor neuron diseases because they progress much faster. You can see them in progressive muscular atrophy, the slowly progressive limb onset, pure LMN motor neuron type, anterior horn cell. There you can see CRDs or complex repetitive discharges more common, but otherwise you tend to see them in chronic radiculopathies. So coming to the last set of abnormal spontaneous discharges that we see when the muscle is at rest, are those that are generated from the motor neuron and from the axon, as you can see in this picture here. And they are actually quite neat. You would have seen that in Shapiro, I'm sure, this picture where they start at a very low frequency, like a fasciculation, which just comes dub, and then a couple of seconds later, maybe, we never know, dub, that sort of thing. So it's very irregular and it's very low frequency, maybe 1 to 2 hertz kind of frequency. And then after that, it sort of goes up a little bit higher in frequency. You have doublets. So you have a group muscle fiber. So 2 muscle fibers giving out this motor unit action potential on screen. They appear together, like doublets, 2 together, triplets, 3 together, or grouped 3 or 4 together, multiplets. Then you see them slightly higher frequency. You have these so-called myokymic discharges, which gives you a marching sound. And that is sort of a group set of muscle fibers, muscle fiber action potentials, a group set of motor unit action potentials. They go chuk, 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 that way. That's the sound. And then you have a cramp discharge where you ask the patient to contract the muscle, and then when they stop contracting, instead of falling silent, you see this continuous sort of discharge, which is like a cramp that comes through. And finally, you have the most high frequency one, which is your neuromyotonia, which is at discharges at 150 to 250 hertz. It is the highest frequency discharge that we record in EMG, and it tends to go wing, wing, like a ping noise, so wing, like that. So this sort of shows you the increasing frequency, one end of the spectrum, and this is the other end of the spectrum. So we'll start with fasciculation. So most of this video is actually fibrillations and positive sharp waves because it's a denervated muscle, motor neuron disease. But right at the start, 2 fasciculations come. I just wanted to see those. Fascic and of fibrillations and positive sharp waves. More positive sharp waves. So we'll just go back just to listen to that fascic again. Fascic, fascic. So sorry. Okay, so that was a denervated muscle with fasciculations as well as fibrillations of positive sharp waves. So as you know, they come from the motor neuron or the axon. They can come from the axon or motor neuron. So hence they can come in, they can be seen in peripheral motor nerve hyperexcitability, which is a peripheral motor axonal hyperexcitability syndromes like I6 syndrome, or they can be seen in motor neuron disease. As you know, they're irregular, they're low frequency, 1 to 2 hertz. I6 syndrome, peripheral nerve hyperexcitability, or motor neuron disease. In motor neuron disease, the presence of fasciculations itself is not enough. It needs to be accompanied by neurogenic motor units. So we'll talk about that in a second. So the other thing about fasciculations is there's this traditional descriptions of fasciculations where they could be complex or they could be simple fasciculations. And initially we were taught that complex is what you see in motor neuron, simple you see in benign cramp fasciculation syndrome, which is one of the benign syndromes where you see fasciculations. But the thing is, you can see both. You can see complex fasciculations in benign cramp fasciculation syndrome. You can see simple fasciculations in motor neuron disease. So there's really no hard and fast rule, although textbooks might mention that, but it's been proven that you see them everywhere. And when we practice as well, there's no real way of differentiating. The only way to differentiate whether the fasciculations are pathological or not is depending on the company they keep. So when you put your needle in the muscle, you record the fasciculations, and then you contract the muscle and you see normal motor units, then that's okay. That's benign cramp fasciculation syndrome or benign fasciculations. But if you then contract the muscle and you see all the features of a neurogenic muscle, where you have reduced recruitment, neurogenic motor unit action potentials, then we are probably looking at something more dangerous. We're probably looking at denervation, and early denervation in motor neuron disease is always with fasciculations, while late denervation, as you see in radiculopathies, fasciculations you see in late denervation in radiculopathies, while early denervation in motor neuron disease gives you fasciculations. So doublets, triplets, and multiplets, this is what they look like. So this is on a rastered trace. So you've got the same potential, so just rastered up. And so you can see the doublet here and then a doublet there. So they fire in groups of 2, 3, or multiple potentials, and they appear in peripheral hyperexcitability syndrome. They can also appear in the early stages of motor neuron disease. But again, they must be associated with neurogenic motor units if you're going to say that they are pathological in motor neuron disease. It's been described. I put it in because it's mentioned in textbooks and things, but we don't really see this very often anyway. It doesn't really come to the lab like that, but the textbooks mention it. So myokymia discharges, so we can go increasing in frequency now. Myokymia discharges, cramp discharges, neuromyotonia. So in myokymia discharges, you see groups of normal motor unit action potentials, and they have a marching sound, as I mentioned. And you see it in radiation. The traditional teaching is that you see myokymia discharges in lumbosacral plexopathy or brachial plexopathy, where radiation has been given. But really, if you look at the what's in the literature and people's observational studies, it's about 50%. So just because you don't see myokymia discharges in somebody who has had radiation, that does not mean that it's not because of radiotherapy. So that's important to know. If it's there, it's helpful in distinguishing between malignant infiltration of the plexus versus radiation damage to the plexus. But if it's not there, it still does not exclude radiation damage to the plexus. Myokymia is always a sign of chronic pathology, chronic denervation, and you can see facial myokymia in brainstem lesions like multiple sclerosis and Bell's palsy. Chronic Bell's palsy, not immediately, you can see myokymia discharges as well. So as you can see here, I've actually compressed the screen at 0.1 second per division so that you can see all the discharges coming together. Towards the end of this video, I open up the screen again back to 10 milliseconds, so you can actually see the group discharges, the group potentials. So now you won't be able to see the individual potentials because I just want you to see what this firing looks like, but then later you'll be able to make out the individual potentials. So those are the individual potentials, and that's a marching sound, the characteristic marching sound that you see with myokymia discharges. Okay. Cramp discharges, very rarely you actually get to record a cramp discharge in the lab, but this is the traditional teaching. So you have voluntary contraction first, and then when the patient stops contracting their muscle, you see this constant sort of same potential coming through, and that's when the patient experiences a cramp. And it's usually benign in most cases, but you can also see it in inherited metabolic disorders like glycogen storage disorders, lipid storage disorders. So here in this video, first you're going to hear the voluntary contraction of the patient. Then you just see, then it sort of ends, that big noise ends, and then you see the potentials coming through, which is a cramp. Sorry. So it's voluntary contraction. That's your cramp potential. Okay, let's try that again. Voluntary contraction. Cramp potential. So the last one here, neuromyotonia, as I said, that's the highest frequency potential that we record, and we record it from the motor axon, not from the motor neuron, from the motor axon. And it has a sort of waning quality to it, like this, like a waning, like a and it's very high frequency. And because it's so high frequency, it sounds very sort of like this ping sound that I was saying. So it's a waning potential, 150 to 50 hertz, ping noise. And you see neuromyotonic discharges. Ideally, you see neuromyotonia, then you're looking at ISET syndrome. But in reality, what we see actually is myokymia discharges seem to be much more commonly seen. Although the traditional teaching is that neuromyotonia means ISETs, and neuromyotonia means peripheral motor nerve hyperexcitability. But myokymia you see more commonly than neuromyotonia itself in peripheral hyperexcitability. So there's going to be a lot of noise at the start of this video, and then later, as it settles, you're going to hear that whing, whing. So just watch out for that. That's neuromyotonia. So it's such high frequency. Okay, so let's do that again. Sorry, back again. Sorry, I'm just trying to play that once more. Give me a second. Yeah. That's high frequency. And that's what you need to watch out for when your needle is in the muscle. So let's go to the motor unit action potentials. So as you can see, there are three main things that we look at actually. So we look at the morphology, we look at recruitment, and we look at interference pattern. So we'll start off with morphology of the motor unit action potential. So motor unit action potential comes up when the patient contracts a muscle. So you need voluntary contraction from the patient. So the bystander can't helpfully lift the muscle up for you. That's not what it is. The patient has to contract. Upper motor neuron, upper motor neuron should be intact. There should be no stroke and all those kind of upper motor neuron lesions. Patient should be able to move the limb, and the patient should be conscious. So you need that to actually get the voluntary contraction in the muscle and to actually see the motor unit action potentials. So we'll start off with the morphology of the motor unit action potentials. In morphology, we look at three things. We look at amplitude, phases, and the duration of the motor unit action potential. So in amplitudes, you record from peak to peak amplitude, and it lasts, and you have increased amplitude and decreased amplitude. So increased amplitude, you see it in neurogenic disorders, that to chronic neurogenic disorders. So amplitude is normal in acute axonal lesions or acute neurogenic disorders. It is abnormal in chronic neurogenic disorder. So you see increased amplitude. Normal amplitude is about 1 to 2 millivolts. You see 5, 4, 5, 6. Up to 3 is acceptable, but once it starts going to about 4, 5, 6, and then that's probably abnormal, as long as it's accompanied by reduced recruitment, reduced interference patterns, and all the other things. You also find that the amplitude increases as long as you have placed the needle correctly in the muscle. If the needle is too far away from the motor unit action potential, then you see very small kind of potential. So you need to make sure, move the needle a little bit so they can hear the crisp sound, and you know that you are well situated in the muscle. And also increased amplitude you see when there's synchronous firing. So this is an example of increased amplitude. So this the sensitivity set is 1 millivolt per division. So you can see 1, 2, 3, 4, 5, 6 millivolts. Some of them are 1, 2, 3, 4, 5, 6 millivolt sizes of the potential, and there's reduced interference patterns, is patchy. There's no potential here, and you're actually seeing the same potential come again, the so-called phenomenon called reduced recruitment that we'll see talk about later. So this is actually a chronically denervated muscle. Decreased amplitude you see in myopathy. So you would have heard that. So high amplitude means neurogenic, low amplitude means myopathy. And that's because there's no problem with the neurogenic side of it. There's no problem with the motor unit, the nerves or the terminal motor axons. The problem in a myopathy is the muscle fiber itself is damaged, and hence what the muscle fiber is able to generate are very small amplitude potentials. Also, you do see amplitudes are quite reduced, abnormally reduced if the needle is a little further away from where you're recording. So remember, when you first get a low amplitude, adjust the needle so that you can hear a crisp sound. You can get a nice, clean motor unit action potential, and then see if it's if it's genuinely a reduced amplitude or a normal motor unit action potential, or actually an increased amplitude. So morphology amplitude wise, increased amplitude you see in neurogenic disorders, reduced amplitude you see in myopathic disorders. We then look at phases. So you would have heard the term polyphasic or multiphasic motor units. So these are complex polyphasic units, or CPUs. And polyphasia is basically the number of times this potential crosses the baseline. So you're allowed to cross up to about 3 to 4 times. But if you cross more than 4 times, you get a potential that looks like this, multiple crossings. And this denotes a neurogenic disorder if it is accompanied by high amplitude and long duration and reduced recruitment. But you see polyphasia also in myopathic disorders if the amplitude of the potential is short and the duration is also short. Now, why do you get polyphasia in myopathic? Polyphasia neurogenic basically means there is renervation going on, renervation and collateral sprouting. But in myopathic, you get polyphasia because there is asynchronous firing. So polyphasia basically happens when there is asynchronous firing. Some of the fibers are firing one time, some other fibers are firing another time. So the motor unit action potential is very increased in duration and high amplitude with multiple phases because of asynchronous synchronous firing in neurogenic disorders. While in myopathic disorders also it's asynchronous because the muscle fiber themselves, they're not firing in symphony, they're firing slightly away from each other, not really in a nice sort of harmonious manner, and hence you get this sort of polyphasic changes in muscle fibers. Now, polyphasia on its own, don't overinterpret it, because a lot of muscles can have polyphasia. So deltoid is the most famous or most infamous muscle. About 25% of the fibers in deltoid are polyphasic. So that doesn't mean it's abnormal unless it's accompanied by fibrillations, positive sharp waves, and other features of motor unit action potential abnormality. But otherwise, in a general, if you take a normal muscle, any other muscle in the limb, up to 10% will have polyphasia. There's also this term called serrations we talk about, where it actually doesn't completely cross the baseline, but you can see multiple turns right at the tops, so-called polyturns. So they're also known as serrations or polyturns. So changes in direction of the potential without crossing the baseline. So crossing the baseline is polyphasia. Not crossing the baseline is serrations or polyturns. Means exactly the same. It means renervation and collateral sprouting in neurogenic disorders. And you don't tend to see serrations so much in myopathic disorders because the potentials completely crowd your screen and you're not able to see the individual potentials properly. Then we now talk about duration. So increased duration and reduced duration. So increased duration along with high amplitude, along with polyphasia if there is renervation, is what you see in a neurogenic disorders. That means there is increased number of fibers, motor unit size is increased. You can also see some level of increased duration in normal individuals who are elderly. So increased age as well can cause some level of increased duration, as well as decreased temperature. So if you're very cold as well, the duration tends to be a little bit more prolonged. So this is what you can see the duration you measure from the point where it leaves the baseline and the point where to which it comes back. So it's about 10 milliseconds normal. So this is about 10 to 15 milliseconds. You can see the duration is prolonged. You can actually see the polyphasia, almost polyturns there. And then you can see the amplitude itself is okay because the the sensitivity is set at 200 microvolts. But if this sensitivity was set at 1 millivolt, then the amplitude also would be very large. It would be 7, 8 millivolts. But because it's only at 200 microvolts, amplitude is also within normal limits. But the rest of it is neurogenic. You see decreased duration in myopathy, as we described before. You also can see very sort of almost polyphasic appearing decreased duration motor units in certain muscles in the body, like the facial muscles, truncal muscles, the bulbar muscles as well, genioglossus. So you have to be really careful on how you interpret that. Be careful by, before calling it a myopathy, for example. And ileoPSOAS. So ileoPSOAS is very, how can I say, is notorious for looking almost myopathic because it has a very sort of scratchy, multiple phasic sort of motor unit. So very careful before you call ileoPSOAS as a myopathic muscle. And it's important because some muscle myopathies are so proximal that you'll only catch it on ileoPSOAS. So it's important to be aware of that. And this is what it looks like when the motor unit action potential in a myopathy shows short duration. So this is a long duration one, and these are so short duration that they almost appear as spikes here. Such short duration, small amplitude. Look at the time base. Look at the sensitivity. It's so low, small amplitude, and they're all crowding together in a phenomenon called early recruitment, which we'll talk about now. So the next thing that you see, and this is one of the most important things when you assess EMG, is recruitment. So recruitment will really make a huge difference to you if you are able to distinguish between the two. So you have reduced recruitment as well as early recruitment. So reduced recruitment in neurogenic disorders, early recruitment in myopathic disorders. And recruitment is a process by which when the patient contracts a muscle, the way the motor unit potentials are activated to produce that contraction. So for example, this is what happens in a normal muscle. So at minimal contraction, the first motor unit starts to discharge. It starts its discharge at about 5 or 6 hertz. So onset frequency is at around 6 hertz, as you can see there. As the contraction becomes stronger and it starts to fire higher, it reaches about 9 hertz and the next potential is recruited. So next potential is recruited. And this recruitment frequency, the frequency at which the first motor unit potential is firing when the second is recruited, is known as a recruitment frequency. That becomes higher in neurogenic disorders, and that is lower in myopathic disorders. So recruitment frequency is higher because there is damage to the motor unit as such because of denervation. And then the first motor unit that is recruited starts firing. It doesn't have many other motor units to come in to help it. So it might fire up to 10 hertz or 12 hertz before the next motor unit comes in from somewhere far. So hence, a high recruitment frequency is what you see in neurogenic disorders, while a lower recruitment frequency, that means very early recruitment for all the muscle fibers, is what you tend to see in myopathic disorders. So recruitment ratio is another concept. So that basically is the frequency of the fastest firing motor unit potential. So for all the potentials on the screen, the one that is firing at the highest frequency, that frequency divided by the number of motor unit potentials that you actually see on the screen. So for example, here if it's about 12, maybe 13, not yet 13, so about 12 is the highest frequency for the first motor unit potential, and there are about 2 or 3 there. So it's just under 5, for example. So that's okay. 5:1 is normal. If you look at the frequency of fastest firing motor unit potential divided by number of motor unit potentials on screen, a 5:1 ratio is okay. A ratio more than 5 is neurogenic, less than 4 is myopathic. So recruitment is a really useful concept because sometimes very chronic myopathies can look neurogenic. And the one thing that will differentiate that from a neurogenic process will be the recruitment. Even chronic myopathies show you early recruitment, give you early recruitment. So that's a clue. So it's very good if you can understand recruitment. Some of the people who have come to the lab, I've seen that so it's sometimes difficult to immediately understand what this recruitment is. So they used to ask, what would be an easy way so that we can look at it and sort of get used to it, because recruitment otherwise is very qualitative. You listen to it and you see it and you hear that sound. In the videos you'll hear it, and it's very sort of qualitative sound that you will understand as you go along, as you experience, get more and more experience. But otherwise, what you could do to help you along is if you keep your screen at 10 milliseconds, and a normal EMG machine has about 20 divisions on here. So 20 into 10 is about 200 milliseconds across. If you see more than 2 potentials on a 200 millisecond screen, then that's reduced recruitment. So in other words, EMG screens at a 200 milliseconds across the entire screen. That means if you just leave it at 10 milliseconds and you have 20 divisions here, a single motor unit firing should not be seen more than twice on its own. That's normal. If it's seen more than twice, that's reduced recruitment. So reduced recruitment is neurogenic. It means chronic partial denervation. Like I said before, recruitment ratio, that means the frequency of firing divided by the number of motor unit potentials on the screen is more than 5 normally. And you see reduced recruitment obviously in axonal loss, but you also see it in pure neuropraxic lesions like motor conduction block, where axonal loss may not have started. So it will be one of the first changes in a neurogenic pathology. It's quite helpful when you have a patient with GBS, you're seeing them in the first 1 week, but they already have weakness, but you're not going to see fibrillations or positive sharp waves because they are only going to develop after 2 weeks. You will not, the nerve conduction studies may not be helpful. So in a weak muscle, if you put the needle in, ask them to contract, and you see the reduced recruitment, you know that there is a lower motor neuron pathology here. So that can be helpful. So sometimes people say reduced recruitment you see in poor activation. Strictly not that true. I put it there because you'll see it in textbooks, but strictly not that true, because poor activation itself, activating a muscle is a central thing. It's a central way of doing it. So if you have a stroke, for example, your activation will be poor, but your recruitment will be normal. If you have a low motor neuron problem, like a motor neuron disease, the patient will be activating fine, but the recruitment will be reduced. So let's have a listen to this one. So that, can you see that it's a hardly any, there's only one motor unit you can really see, and it fires at a high frequency. And at one point, you see almost 3 motor units on the screen together. So that's a way of knowing that's reduced recruitment. Just listen to this one as well. So it's fibrillations, positive sharp waves. So CRD, that's a complex repetitive discharge. Activated muscle. So the kata sound, that's reduced recruitment. So that's the kind of sound that you'll get used to as you go along. And then that's really helpful if you can differentiate, use that to differentiate. So reduced recruitment, neurogenic disorders. Early recruitment, myopathic disorders. As simple as that. Recruitment ratio is less than 4. Because what happens in myopathic disorders is that these muscle fibers are lost. The motor unit itself is normal. I mean, the motor neuron and the motor axons are completely normal, but you have the muscle fibers which are actually lost. So when you start to contract, ask a patient to contract a muscle, for that same amount of force, you need the help of multiple muscle fibers, because the muscle fiber that is available to you, your motor neuron is firing rapidly, it's really firing because it's working normally. But the muscle fiber that is available to you are fewer number of muscle fibers, and hence it starts recruiting very early. And that's why at very minimal contraction, you get a screen full of short duration, small amplitude motor units like this. So here we go. So it's minimal contraction. So here you can see their short duration, their small amplitude is at 500 microvolts, and they are crowding the screen. And you can see them all getting recruited quickly. You can't see the individual motor units because at small contractions, they just keep recruiting, and the interference pattern is also normal. So this is another clip of a myopathic patient, but they also have fibrillations and positive sharp waves, which you see in inflammatory myopathy, for example, or any myopathy where there is myonecrosis as well. So you can see the positive sharp waves. That's voluntary activity, but you can see the positive sharp waves in between. So when the instruction is given to contract, there's a quick contraction and multiple motor units come into play. So that's early recruitment. The last one is the interference pattern. So remember, activation is central based on the upper motor neuron, based on patient cooperation, while recruitment is low motor neuron. So you have a full interference pattern. If it's a normal muscle, like here, where you ask them to contract, complete interference pattern, or you have a myopathic muscle where you have a complete interference pattern again because of the crowding of the muscle fibers, because multiple muscle fibers come into play to generate the same amount of force. Reduced interference pattern could be due to, it shouldn't really say poor activation. Poor activation is fine. That's a central problem. So the interference pattern is reduced in that, as well as in neurogenic disorders. So in neurogenic disorders, you also see reduced recruitment. So you see reduced interference pattern with reduced recruitment in neurogenic disorders or denervation. And you see just reduced interference pattern with normal recruitment in poor activation, which could be due to poor patient cooperation or due to upper motor neuron lesions, issues. So just to quickly sum up, patterns of motor unit potential abnormalities, neurogenic ones will be acute axonal loss, fibrillations and positive sharp waves, if it's after 2 weeks at least, with reduced recruitment. So remember, recruitment is important. Morphology of the motor units will be normal. So there wouldn't have been time for reinnervation. So there wouldn't have been time to have the long duration, to develop the long duration, to develop the high amplitude and the polyphasics. So that all that will be normal. The morphology of the motor unit action potential itself will be normal. Chronic axonal loss, you can still get fibrillations of positive sharp waves. Reduced recruitment will be there. Reduced interference patterns will be there. Motor unit potentials, abnormalities will be seen in chronic denervation or chronic axonal loss. That is increased duration, increased amplitude with polyphasia and reinnervation, resulting in something called unstable motor units and satellite motor units. And this is partially denervated when some of the motor units are affected, while the other unaffected motor units adopt so-called the other muscle fibers from the affected motor unit, giving rise to sort of this long duration and polyphasia. So these three things that you see in reinnervating motor units, one is a satellite motor unit. So you can see when a potential comes across the screen and there is a smaller potential time locked to it, attached to it like a little puppy dog. That's a satellite unit, and that's a sign of reinnervation. You can then also see in the screenshot here, a small, long duration, small amplitude, but long duration motor unit potential with polyphasia, multiple polyphasics with positive sharp waves. Probably a fib there, difficult to say. So that is also a sign of reinnervation. So satellite unit is a sign of reinnervation. Polyphasia, small amplitude, long duration, polyphasic motor units are a sign of reinnervation, and also something called unstable motor units. Unstable motor unit means the same motor unit keeps firing, but every time it fires, it changes its morphology because it's reinnervated. It's partially denervated and it's reinnervated. So here you can see the same motor unit firing on sort of vertically placed traces or rastered traces. And you can see they keep changing. You can hear the reduced recruitment also, that brrr sound. And you can see the polyphasia as well. So it's the same motor unit potential, but it keeps changing its morphology. So in myopathy, you can have spontaneous activity like fibrillations and positive sharp waves if it is a dystrophic process, or if there is active inflammation like a polymyositis. You'll see early recruitment, short duration, small amplitude, and polyphasic motor units. So just to quickly sum up on these, Normal, these are all your normal parameters here. Neurogenic, you know this already, increased duration, increased amplitude. Polyphasic, spontaneous activity will be present. Fibrillations, positive sharp waves, for example. Fasciculations with neurogenic motor units means, which is abnormal, you need to think about motor neuron in such cases, depending on the clinical presentation. Recruitment is reduced, interference pattern is reduced. In myopathy, duration is reduced, amplitude is small or reduced. The phases are multiple because of asynchronous firing. Spontaneous activity may be present if it's a dystrophic myopathic process or if it is an inflammatory myopathic process. Early recruitment and a full interference pattern. So reduced interference pattern in neurogenic process, full interference pattern in myopathic process. So just a quick, before we start going into assessment of different disorders quickly and looking at those cases, just to have a quick look at what you do when you are faced with, you have a EMG needle in your hand and a muscle and you need to look, how will you go about it? So first put the needle in the muscle, make sure the patient is relaxed, muscle at rest, make sure that the muscle is completely at rest, and then look for abnormal spontaneous activity in the form of fibrillations, positive sharp waves, or fasciculations. You might need to look a little bit longer for fasciculation potential. Some people say 90 seconds. We don't have that kind of time, but sometimes we are forced to when we have to make a diagnosis of motor neuron disease, and the fasciculations presence or absence would be make or break. Once you've seen the spontaneous activity, if there are fibrillations or positive sharp waves, you then ask the patient to contract the muscle. So voluntary contraction to assess motor unit potentials and the recruitment. Okay, so if it's myopathic, that means early recruitment with short duration, small amplitude, polyphasic motor unit potentials, you can then label it as a myopathy with myonecrosis, either acquired inflammatory myopathy or inherited muscular dystrophy or dystrophic myopathy. Okay. Suppose the patient contracts a muscle and then you see neurogenic changes. That means reduced recruitment with long duration, high amplitude, polyphasic motor unit action potentials. It's active on chronic denervation with or without reinnervation. So if there are polyphasic motor unit potentials, it's a sign of reinnervation. If there are satellite units, it's a sign of reinnervation. If the motor unit potentials look unstable, also a sign of reinnervation. Now, if suppose you're looking at the muscle at rest and there are no fibrillations or positive sharp waves, you still contract the muscle, you want to see what motor unit potentials are there. Myopathic changes, early recruitment with short duration, same thing. That means myopathy without myonecrosis because no fibrillations and positive sharp waves. Neurogenic changes, you see chronic denervation with or without reinnervation, but no active denervation because there are no fibrillations or positive sharp waves. If you have fibrillations or positive sharp waves, and you have normal motor unit potentials but reduced recruitment, that would be those unusual times when there could be early neurogenic changes. So just active denervation without any motor unit potential abnormalities, like you might see in early radiculopathy, for example. So once you have determined in a muscle what is going on, is it myopathic, is it neurogenic, is it active myopathic, is it active denervation? Once you've determined that, then repeat the same process in other muscles to look at the distribution and try and localize. One little thing that's quite useful to remember is if you have a history that is less than 1 week, very clearly reliable history from the patient or the bystanders, and if you find fibrillations and positive sharp waves at that point, which you shouldn't in a neurogenic disorder, then you're likely looking at a myopathic process. So early fibrillations or positive sharp waves within 1 week from onset of symptoms, it's likely a myopathic process. And it would be helpful if you can get some voluntary contraction to try and see whether the motor unit potentials are myopathic or not. But sometimes you might be stuck in such a situation where the patient is comatose, for example, where you have no voluntary contraction. So this is something that you can think about. Early fibs and positive sharp waves within a week of onset of symptoms could be myopathic. Okay, so quickly go through evaluation of radiculopathy, just 3 cases here. So I think we had already spoken about radiculopathy, preganglionic, postganglionic in the previous discussion. So in a normal potential, you see the normal SNAP or sensory nerve action potential, normal compound muscle action potential. In preganglionic or proximal, the sensory nerve action potential is normal because you measure your sensory nerve action potential in this bit from dorsal root ganglion to the skin, while the motor potential may be abnormal depending on the pathology. So preganglionic is proximal, which could be root or anterior horn cell. Postganglionic means distal, which could be plexus or peripheral nerve, where the sensory nerve action potential as well as a compound muscle action potential both may be affected. So what are the principles of electrodiagnostic evaluation in radiculopathy? So sensory nerve action potentials, by definition, because it's a preganglionic process, is mostly normal. There are exceptions like the intraspinal ganglion in L5 and S1, but vast majority of cases, the sensory nerve conduction study is normal, as long as there is no coexistent problem, coexistent postganglionic problem like peripheral neuropathy, for example. So I've given a few examples here. For example, how do you differentiate ulnar neuropathy versus C8 radiculopathy? So you're looking for an abnormal digit 5 snap or dorsal ulnar cutaneous snap, which will point you towards a postganglionic disorder such as ulnar neuropathy. In plexopathy as well, it's postganglionic, so you'll see abnormal nerve conduction study, sensory nerve conduction studies. In CTS versus C6 radiculopathy, again, you'll see abnormal median snaps, which is postganglionic in carpal tunnel syndrome with focal demyelination. In peroneal neuropathy versus L5 radiculopathy, again, you're looking for abnormal superficial peroneal or deep peroneal sensory responses. Motor studies in radiculopathy are not that useful because you only see reduced compound muscle action potentials or reduced motor responses in chronic radiculopathy. So in acute radiculopathy, you don't see reduced compound muscle action potentials as long as it's compressive. Sometimes in non-compressive polyradiculitis, as you might see as part of an immune-mediated diabetic polyradiculitis, there you can see a reduction in the compound muscle action potentials more often than in a compressive radiculopathy. But by most of the cases, really the CMAPs are not that helpful. FPs have very low sensitivity and H reflex. People use it, but if you can do your ankle jerk by yourself, H reflex may not be required. EMG is the best test for radiculopathy. It's more sensitive. You've got the numbers there for sensitivity. You're looking for active denervation plus or minus chronic denervation. So if it's very early, all you'll see is reduced recruitment. If it's 2 weeks or 3 weeks into the illness, you will see some fibrillations or positive Sharpies, hence active denervation will be there. If it's 2 months, 3 months, 4 months, it's chronic denervation. So you will see active fibs and positive Sharpies along with chronic changes. And the role of EMG, the principle, what you need to try and do is demonstrate abnormalities in 2 or more muscles innervated by the same nerve root and 2 peripheral nerves. So for example, to demonstrate a C8 radiculopathy, you need to show denervation in ulnar innervated C8 muscle like FDI, for example, and a radial innervated C8 muscle, for example, like extensor indicis proprius. No correlation between symptom duration, presence of active denervation in paraspinal limb muscles. So it used to be taught to us that the denervation that starts in paraspinal muscles and then goes on to limb muscles actually depends on the duration. And there's been some recent studies which suggest that's not true. So it doesn't really mean that the paraspinal denervation is acute, even though we feel that is, and people have taught in that way. So that it doesn't hold true any further. Fibrillations you can also see in root compression as well as chemical radiculitis. When I say chemical radiculitis, sometimes we know that patients have compressive radiculopathy where there's no direct compression of the nerve root, but there are changes in the CSF around the nerve root, which almost results in a chemical radiculitis. So you can see fibrillations in such patients as well. So the protocol for sensory nerve action potential. So when you have a patient who complains of sensory symptoms in the C6 distribution, for example, in median, in the thumb, they say I've got radiating pain from the neck, and then I got gingival paresthesia, something in the thumb. What you need to do is a sensory nerve action potential from the thumb, recording from stimulating the median nerve. And if that's normal with the sensory symptoms, it's likely you're looking at something preganglionic, in this case, a root. Okay, so snaps are usually unaffected because it's preganglionic. L5 and S1 are exceptions, but again, they are very much, they're rare. You don't really see that sort very often. So this is just a list of different sensory nerve action potential studies that you can do for different nerve roots. So this is useful to have a set of muscles that are so-called your favorites for each nerve root. So you have C5, you can think maybe deltoid, rhomboids, infraspinatus. Make sure you're comfortable needling these muscles. So if you can then demonstrate damage, denervation in deltoid and infraspinatus, that means 2 different muscles with 2 different nerves, but same nerve root, then you can show that there is that it localizes to that particular nerve root. So in the same way, C6 brachioradialis pronator teres, C7 triceps, extensor digitorum communis. Unfortunately, both are radial. So you might have to go for pronator teres or flexor carpi radialis. Pronator teres has more C6, while flexor carpi radialis has a bit more C7. So these are two muscles you can choose for C7. C8, you have first dorsal introsseous. You can choose flexor pollicis longus, which is median, or extensor pollicis brevis, which is radial, extensor indicis proprius, which is radial, flexor carpi ulnaris, which is ulnar. So you have different muscles. So it's a good idea to have a few favorites of your own. T1 is almost always adductor pollicis brevis. It's the best muscle for it. And going to the lower limbs, you have L3 adductor, L2, L3, very difficult to be sure because the innervation is it's not so clear cut. While L4, L5, S1, it's a bit more clear cut. L5, extensor hallucis longus is a good L5 muscle that is innervated by peroneal nerve, while flexor digitorum longus or tibialis posterior, both are innervated by the tibial nerve, and these are very good L5 muscles. So if you show denervation in both these, that is supplied by two different peripheral nerves there, but from the same nerve root, you can then localize it to the nerve root L5. Same goes for S1. You can choose the short header biceps femoris and medial gastrocnemius. Only problem is sciatic might be common for both. So you can then have something like gluteus maximus, but the problem with gluteus maximus, it's a large muscle. So if there's patchy denervation, you might miss it. So these are things you need to think of and make sure you have some favorite muscles for different nerve roots. So our first case, 50-year-old male, very brief, maybe 2-month history of right-sided neck pain, paresthesia. So classical radiculopathy symptoms, nerve conduction studies are normal, sensory and motor. It's quite recent. It's only 2 months, so motor studies are also normal, acute radiculopathy. So the muscles that have been looked at, biceps, pronator teres, and triceps are showing fibrillations of posterior sharp waves. And interestingly, some level of chronic denervation is also seen. So this has probably been going on for a bit longer, 1 month, 2 months. And the presence of sensory nerve action potentials, which are normal, makes us preganglionic. Sorry. Makes it preganglionic, and the distribution of abnormalities is pronator teres shows more fibrillations of posterior sharp waves, while biceps and triceps shows less fibrillations of posterior sharp waves. So pronator teres having more C6 than C7. Biceps also has C6, triceps has a little bit of C6. So it looks like C6 is more affected. Now biceps is also quite C6, but biceps being a larger muscle, its pickup rate is not as good as pronator teres for C6. So here you have a C6 denervation is more pronounced compared to C7. Now suppose the EDC, extensor digitorum communis, the extensor forearm muscles had also significant denervation, then it would be more C7 because EDC doesn't have hardly any C6. So that's how you eliminate these things. And you see the distribution is more in C6 more than C7 because pronator teres is affected more than biceps, which is affected more than triceps. And you have a C5, C6 herniation with traversing C6 radiculopathy. And you have shown most of your denervation is in the C6 myotomes. So because there are so much multiple innervation in multiple muscles, you can't really have a clear-cut C6 denervation. It'll spill over a little bit into C7 innervated muscles, a little bit into C5 innervated muscles. But you'll have to, that's why you have to do multiple muscles to try and bring it sort of narrow it down to a common nerve root. So remember, multiple muscles need to be done with overlapping nerve roots. So another radiculopathy case, this time a lumbosacral radiculopathy, right-sided low back pain. Some weakness is there, unable to stand on the toes, absent right ankle DTR. So there is some suggestion this could be an S1 involvement. Normal sensory nerve action potentials, as you would expect in a preganglionic condition such as radiculopathy. Absent right H reflex, which matches with your clinical finding of absent right ankle reflex. Normal motor responses because it's quite acute. Some prolongation of the tibial F wave. Don't make a diagnosis of radiculopathy just based on F waves. Make sure that EMG abnormalities are also present. So when you look at EMG here, gastrocnemius shows quite a lot of fibrillations, positive sharp waves, and quite a bit of chronic changes. So it's likely he had symptoms even before that. Maybe he didn't bring it to our notice. So tibialis anterior also shows some fibrillations and positive sharp waves, but less compared to gastrocnemius. So this is more L4, L5. That is more L5, S1 especially. Extensor hallucis longus is more L5, while biceps femoris is more S1. So you can see as it goes, the S1 muscles seem to be more affected. So that's why it's important to do different muscles. And the L5 muscles, that is gluteus medius, as well the tibialis anterior and extensor hallucis, are less affected because L5 compression is less. And that matches with your absent ankle DTR. And like I said, this has probably been going on for a bit longer than what was brought to our notice, because there is some chronic denervation changes with increased duration. While the tibialis anterior extensor hallucis, as long as the L5 muscles are not showing the chronic changes. So the distribution, so first it's preganglionic because sensory nerve responses are normal. Secondly, the distribution, there is L5 and S1 involvement, but S1 involvement is more than L5 because gastrocnemius and short head of biceps femoris, both predominantly S1 muscles, are more involved than extensor hallucis longus, gluteus medius, and tibialis anterior, which are predominantly L4, L5, especially L5 muscles. So here we have the disc herniation and compression of the traversing S1 root. So these are two straightforward radiculopathy cases. Clinically and electrophysiologically, they match. Now, this is a patient I had recently, which is not that straightforward. So it's a slightly elderly man with some vague left upper limb pain and with definitely some weakness in shoulder abduction. Reflexes were absent. And the sensory nerve conduction studies were normal. So sensory nerve action potentials were normal. And if you look at the motor studies distally are normal. Amplitudes are normal and the conduction is normal. Radial is also normal. But if you see the left brachial plexus studies, that means the biceps from musculocutaneous, biceps recording, stimulating musculocutaneous, deltoid recording, and supraspinatus recording, they are reduced compared to the right side. So something proximal is going on involving C5 and C6. And it seems a little bit chronic. Because remember, in acute radiculopathy, you will not see the abnormality in motor studies. When you do the EMG, you can see the denervation. And the denervation is quite scattered, actually. You can see it in deltoid, you can see it in first dorsal intraossei, in biceps, in triceps, and all in one sort of one limb, and also in T1. So again, sensory nerve action potentials are normal. So again, it becomes preganglionic. So when you say preganglionic, remember, because we are discussing radiculopathy, we have a tendency to think it's radical root, but preganglionic also includes anterior horn cell. In the other two cases, we had clear radicular symptoms, so we could confidently say that sounds more like radiculopathy, and the denervation was very localized. But here, denervation is a little bit more distributed, not so localized. There is C5, C6 denervation, there is some C7, C8, T1, and what we see in C5, C6 seems to be more chronic, while C7, C8, T1 seems to be more acute. So yes, it could be a radiculopathy. And multiple levels, and we need to image to make sure there is no compression, or it could be a non-compressive radiculopathy, less likely. But it's also important to think whether this could be an evolving anterior horn cell disorder, because there are multiple levels that are involved, and it is preganglionic. So preganglionic could be root or motor neuron, but at multiple levels, it's a little unusual to be just root. We have to exclude root, obviously. And if root is normal on imaging, then the next question really is that whether this could be an evolving anterior horn cell disorder, in which case you may need to repeat the studies. So when you refer for EDX studies in patients with radiculopathy, when there are motor deficits, it is important that you refer, because you then know that there is evidence of active denervation. You want to demonstrate it just in case that the patient needs to go for surgery. Also, there is a diagnostic dilemma. So the patient has sensory symptoms. You don't know if it's carpal tunnel syndrome, ulnar neuropathy, or whether it's a C8 or T1 radiculopathy. So exclude peripheral nerve disorders. Also, it will help to identify the root. So where we had the confusion between L5, S1, doing the EMG will tell you, okay, that looks more like S1 rather than L5, that sort of thing. Also, as you do MRIs, a lot of patients have vague pains, and we tend to do MRIs. When we do MRIs, what we find, multiple levels of compression might be seen, spondylosis might be seen. But the problem is that we don't know whether this is clinically significant or not. And the clinical presentation may also we may not be able to match up with the clinical presentation and the MRI. In such cases, EMG is helpful because the EMG clinical concordance is much higher. So if the patient has clinical symptoms in one region, and if that is because of denervation there or radiculopathy there, the EMG will be abnormal, even if the MRI does not show any abnormality. So the EMG clinical concordance is higher. The other time it will be helpful to do EMG in a patient with suspected radiculopathy is if the MRI shows compression at multiple levels and you want to identify which is the most clinically affected routes. This is also helpful for surgeons before preparing the patient for surgery. So we'll go on to motor neuron disease. Now, how do you evaluate patients with motor neuron disease? First case, straightforward one. So you have a patient who's in her 40s. There is some family history with atrophy. You can see atrophy in the muscles in the hands, both the dorsum as well as the palmar regions, quite a lot of atrophy. But the interestingly, deep tendon reflexes are preserved. So there are signs that this could be UMN, upper motor neuron signs, as well as lower motor neuron signs of atrophy. The sensory nerve conduction studies are normal, so completely normal median snap, ulnar snap, superficial peroneal, and sural snap. So when you have somebody with a clinically wasted muscle with normal snap, it becomes preganglionic. Again, you have to say, when you say preganglionic, you have to say it's root versus anterior horn cell. You can't immediately say it's anterior horn cell. You have to prove it's anterior horn cell, because these are still the two possibilities that you are looking at. Motor axonopathy is another possibility that should be there. That means it's pure motor axons. We know that such conditions are highly rare and we hardly ever see them, but these are the three things that you should keep in mind as you continue the evaluation. So motor nerve conduction studies, as you can see here, the amplitude is extremely reduced, more in the thenar eminence, less in the hypothenar eminence. And as you see, more in the thenar eminence, intraocular, first dorsal intraocular and APB. And you can see reduced amplitudes in the lower limbs as well. So reduced motor amplitudes, CMAPs, conduction is normal. So there is no features of demyelination. Motor axonopathy or neuronopathy still is something that you need to think of. You have to keep the possibility of motor axonopathy, because unless you show diffuse denervation, it's still theoretically possible. But otherwise, neuronopathy, or in other words, motor neuron disease, is the first possibility here. Cervical and lumbosacral segments are affected because the median, ulnar, their cervical, peroneal, tibial are lumbosacral. So if you look at the denervation, you can see there's quite a lot of denervation in the cervical segments. There is denervation in the thoracic segments here, fibrillations of positive sharp waves with neurogenic motor units, and in the lower limbs, that is the tibialis anterior, gluteus medius, gastrocnemius vastus, and in the genioglossus also you can see fasciculation potential. It's very difficult to record fibrillations and positive sharp waves in genioglossus, but fasciculation potentials you can see with neurogenic motor units. So cervical is involved, thoracic is involved, lumbosacral is involved, and cranial is involved. So all four segments are involved. So it's a diffuse neuronopathy or diffuse motor neuron disease. So when you go to your opinion, nerve conduction studies, normal sensory nerve action potentials, reduce CMAPs, that's what we saw. Reduce CMAP amplitudes with normal conduction. So again, we had to call it motor axonopathy or neuronopathy because those were just the limbs. But when we did the EMG, we saw active on chronic denervation in multiple levels. Fasciculation potentials counts as active denervation according to the Awashima criteria. We'll go to that in a second. So there's diffuse denervation, and this is consistent with the diffuse anterior horn cell disorder. And in this case, because there are upper motor neuron lesions as upper motor neuron signs as well as lower motor neuron signs, you can label this as definite ALS. So what are the pattern of EDX abnormalities in anterior horn cell disorders? So now sensory nerve potentials by definition should be normal. Sensory nerve action potential should be normal, unless there is a coexistent peripheral neuropathy or some entrapment syndrome, or in elderly people, their nerve conductions might be, sensory responses might be slightly reduced in the legs, or in Kennedy's disease, for example, there is some suggestion that there could be some, unrelated sensory abnormalities also in motor neuron disease, but that's just early days. We don't know. Research is going on there. Abnormal motor conduction studies is something that you see always because it's preganglionic. There is axonal loss, amplitudes are reduced, and if the symptoms start in a single limb, it's important to compare with the opposite limb. Important to compare the motor studies with the opposite limb. Also important to make sure there is no conduction abnormalities. Exclude demyelination, especially if you are dealing with a lower motor neuron type of motor neuron disease, and exclude peripheral nerve involvement, obviously. EMG, again, like radiculopathy, is the most important test that you do here. You're looking for abnormal spontaneous activity, both in the form of fibrillations, positive sharp waves, as well as fasciculation potentials. They ideally should be accompanied by chronic denervation changes in the form of neurogenic motor units with reduced recruitment. And then you have to evaluate for and document subclinical element dysfunction. So if the patient has symptoms in one limb and you show low motor neuron dysfunction in the clinically unaffected limb, it has a high predictive value for motor neuron disease. The next thing is you need to see what is the segmental involvement. How is it involved? So your motor neuron, your cervical segments are involved. You have a clue from motor studies. EMG shows the same thing, low LMN findings. Then your lumbosacral is involved. Then you have to look at thoracic and craniobulbar using EMG, and that tells you at how diffuse the abnormality is. Also helps you classify the disease. So this is a classification that we use. So there are 3 now available. The most recent is a Gold Coast criteria, which came out in 2019, 2020. This is what we've all been using for a long time, but this is probably what's more useful. This is Awajishima criteria. Now, so you have definite, which is 3 segments that are involved. Probable, that means 2 segments, that is lower motor neuron and upper motor neuron signs in 2 regions with some upper motor neuron signs, that is cranial or rostral to low motor neuron. For example, this will be a patient who has UMN and LMN in cervical, that I'm talking about probable, UMN and LMN in cervical segments as well as lumbosacral segments with a brisk jaw jerk, for example, and dysarthria, nasal speech in the pseudobulbar palsy in the cranial region. So you have UMN cranially, but LMN and UMN combination is present only in 2 regions, and those kind of patients, if you label them as probable. They used to say probable lab supported, where you have LMN and UMN only in 1 region with LMN findings on EMG in 2 regions. Now that has been taken away in the Awajishima criteria, because in the Awajishima criteria, what the difference they made is that LMN clinically is equal to LMN electrophysiological. So in other words, you don't have to have low motor neuron signs clinically. If you have low motor neuron signs in the form of denervation electrophysiologically, that's as good as having low motor neuron signs in that region. In addition, in the past, it used to be just fibrillations and positive sharp waves that were counted, but now fasciculation potentials along with neurogenic motor units are also counted. Gold Coast criteria is much more loose. If you can show progressive motor impairment and LMN and UMN in just 1 region or LMN in 2 regions, and you have to exclude mimics. The key thing is you have to exclude the mimics, and the LMN could be both clinical or EMG, just like Awajishima, then you have your diagnosis. So the sensitivity, specificity is pretty good. So we should really be, though we've been using Awajishima up to now, we can slowly start moving to Gold Coast criteria, because a lot of the atypical motor neuron diseases, if you apply the Gold Coast criteria, they tend to become positive. So the next case, right foot drop, no sensory symptoms, occasional back pain, may not be significant. So there is atrophy in the leg muscles with some UMN signs, but the plantar response is flexor. Sensory nerve conduction studies are normal. So right foot drop with normal right superficial peroneal and normal right deep peroneal. That means the snaps are normal. So peroneal neuropathy is less likely. Then you see the motor studies and you actually see a reduction in the motor amplitudes of the peroneal nerve and the tibial nerve, even though he doesn't have any clinical weakness. Maybe it depends, it's not really mentioned here. But ankle jerk is brisk. So you have a preganglionic localization. So you have normal sensory conduction studies with preganglionic localization on motor studies. So preganglionic involvement of right L4, L5, and S1. L4 because peroneal tibialis anterior is also affected. So when you do your EMG, you can see active denervation with neurogenic motor units in the lower limbs. Lumbosacral segment is affected. Interestingly, both sides are affected. So the clinically uninvolved side is also affected. So that has a high predictive value for possible motor neuron disease. The next thing you find is your thoracic. So the moment you see bilateral denervation in somebody with unilateral symptoms in one segment, like this lumbosacral segment, you have to move a segment above to try and find out if there's denervation there. And the denervation here follows the Awagi-Shima criteria where there are fasciculation potentials, no fibrillations and posterior sharp base in thoracic paraspinal muscles. It can be quite difficult to document fibrillations of posterior sharp base in thoracic paraspinal. So if you have fasciculation potentials, that's good enough as long as it is accompanied by neurogenic motor units. So there is lumbosacral involvement and there is thoracic involvement, but cervical is not involved. A few polyphasics and deltoid is fine. We know that it's normal. So the classification here will probably be, according to the revised LS corneal criteria, according to Awagi-Shima criteria, would be probable ALS, lab supported for revised LS corneal, or just probable ALS, because you have UMN and LMN in lumbosacral, you have LMN in thoracic. So UMN and LMN in lumbosacral and LMN on EMG. And thoracic, you have LMN on EMG. So LMN in two regions, that's lumbosacral and thoracic on EMG, while UMN and LMN together in one segment, but because it's lab supported, it becomes probable lab supported, but not probable ALS. The next case would be similar. It's similar. So again, a 4-month history of right lower limb weakness without significant unilateral sensory symptoms. However, he does have some paresthesia in both feet, but he is diabetic. He has DM, he is diabetic. And when you look at the sensory nerve conduction studies, which are usually normal in motor neuron disease, you can see there's a length-dependent neuropathy here. So the superficial peroneal and the sural responses are reduced for his age. And the ulnara, okay, probably reasonably all right, but there's definitely some level of length-dependent axonal sensory loss here. But if you look at the motor studies, the amount of damage, the amount of reduction in amplitudes in the motor responses is much more severe. They're in microvolts, so it's much more severe. So there's definitely a preganglionic involvement here. So sensory nerve action potentials show reduced amplitudes, which are length dependent. CMAPs also show reduced amplitudes, but it is definitely out of proportion to the snaps. And there is asymmetrical axonal involvement. So if you see the right tibialis anterior and left tibialis anterior, right tibialis anterior is in microvolts, where left is a little bit better. So it's asymmetrical axonal involvement of either the right peroneal L4 or L5. It's unlikely to be right peroneal because the right superficial peroneal is as involved as the left. So it's likely there is a preganglionic pathology going on here. When you do the EMG, you can see that there are complex repetitive discharges. It's a chronic condition there, and there are bilateral active denervation changes with neurogenic motor units. There are some chronic denervation changes in the upper limbs as well, as you can see in the biceps and the deltoid, but no active changes. Active denervation is important. That's what you're looking for. So we know there's a length-dependent, symmetrical, sensory axonal peripheral neuropathy, but that should not put you off the diagnosis of motor neuron disease. Like I said, coexistent peripheral neuropathy may be there, but that doesn't mean that everything is because of peripheral neuropathy. This level of denervation you will not see in just a simple sensory axonal neuropathy, as well as the motor amplitudes that you saw before. The motor responses are affected out of proportion to sensory responses. And hence there is some level of preganglionic localization to bilateral L4, L5, and S1. So the classification then would be, if you use revised LS corneal, ALS, possible ALS, if you can also demonstrate upper motor neuron in the lower limb. So UMN plus LMN in one region is possible ALS. Because on EMG, only lumbosacral segment is affected. The thoracic muscles are not affected. So the segment above the lumbosacral is not affected. In such very localized situations, it's really important that you exclude a radiculopathy, because that's something treatable. You can do something about it. The prognosis is different for the patient. So it's important that you exclude a radiculopathy when it's very, very localized like this, with even thoracic is spared, upper limbs are spared. If in doubt, just repeat your studies, repeat your electrophysiological studies. The next case, again, a middle-aged man with weakness of both upper limbs, left slightly worse, quite weak actually, almost like the so-called person in barrel syndrome, not able to lift his proximal arms, upper limbs, and the deep tendon reflexes are absent. So there's definitely a low motor neuron component there. Sensory nerve conduction studies are normal, as you can see, preganglionic localization. So that's preganglionic. The motors, if you actually see the proximal motor studies from muscular cutaneous, they're more affected Even left was more affected than right compared to the distal studies. Distal studies are also not normal. They are affected in the thenar eminence, the median motor study, but not as much as a proximal study. So there's definitely a proximal axonopathy, which is preganglionic. Again, root versus anterior horn cell is what you think of here. But there are no sensory symptoms, so root seems less likely. Distal CMAPs normal, proximal CMAPs abnormal, as we mentioned. We start our EMG. So we start from proximal. Fasciculations are present in deltoid. Neurogenic motor units, very reduced interference patterns, lots of fibs and positive waves. So here we go, your cervical affected, quite badly affected, but lower limbs is fine. Thoracic, maybe something is there, something is starting. There is reduced recruitment, reduced interference patterns, but there is no active denervation. In the absence of active denervation, we cannot denote this muscle as, denote this region as being abnormal. We need active denervation. So essentially thoracic, paraspinal muscles, as well as bulbar, genioglossus or tongue, as well as lumbosacral is negative. So you just have one region, low motor neuron dysfunction. So it's a pure low motor neuron syndrome affecting cervical segments. There is no evidence of demyelination motor nerves. It's important when you are faced with a pure element syndrome to make sure that you're not dealing with a multifocal motor neuropathy with or without conduction blocks. So very important, because those are treatable conditions. Very important to exclude demyelination. There is some degree of asymmetry, agreed, but that's neither here nor there. It really doesn't make a difference. But essentially, to us, it's unclassifiable. Even if you apply the Gold Coast criteria in this case, in the absence of UMN findings and LMN only restricted to one segment. Remember, you don't have any fasciculation potentials or active denervation changes in thoracic. And hence, if LMN is only restricted to one region, Gold Coast is negative. For Gold Coast to be positive, LMN has to be present, LMN findings has to be present in two regions. So we don't have actually LMN in two regions, only in lumbosacral. So it's unclassifiable. It's what we used to call the brachial amyotrophic diplegia or person in barrel syndrome. So we're almost nearing the end of our motor neuron assessment. So this is again a 43-year-old male with a left hand weakness this time, no real sensory symptoms. So very LMN, absent upper limb deep tenor reflexes, atrophy is present, normal sensory nerve action potential. So now we're used to it. We know it's preganglionic. Reduced compound muscle action potentials in left C81. So you can see this is T1, and because it's a pure element syndrome, and a pure motor element syndrome, stimulation has been done more proximally at Erb's point to make sure that we are not missing any proximal demyelination. Same goes here for left ulna FDI and left ulna ADM, but the thenar muscles, that is the first dorsal intraosseous and the abductor pollicis brevis muscles, are quite severely affected. Lower limbs are fine, lower limbs are fine. So when we start doing EMG, there are fasciculation potentials in the biceps, and that associated with neurogenic motor units makes it an abnormal muscle in motor neuron parlance. APB and FDI with neurogenic motor units, again, there's active denervation, so that's also involved. As you go lower down, the lower limbs are within normal limits. There are some chronic denervation changes in the quadriceps, but nothing active. Remember, we need fasciculation potentials or fibrillations of posterior sharp waves here. Again, chronic denervation changes in thoracic muscles, paraspinal muscles, but again, we don't have anything active here and nothing in genioglossus. So these are all chronic changes. In the upper limbs, the EDC is chronic, and these are chronic, but active on chronic denervation. You did see in the C6, C8 and T1 distributions, not clearly in the C7 that you could demonstrate. So chronic denervation in thoracic paraspinal muscles don't count because you need active denervation as well. So again, this is a pure low motor neuron syndrome affecting one side, but there's no motor nerve demyelination. So it's very restricted neuronopathy just in the cervical segments. Currently, there is no evidence for a diffuse anterior horn cell disorder, unclassified. Remember, it's important, even if the patient doesn't have sensory symptoms, to make sure that you do MRI, because MRI of the spine, you need to make sure that you're excluding treatable causes. So how do you plan your examination in a patient with motor neuron disease? So if it's bulbar onset, ideally you should go for your bulbar craniobulbar muscles. Genioglossus is the muscle that everybody prefers, and this is usually the way to do it. Some people put the needle in through the intraoral route, which is very uncomfortable for the patient. I prefer this, it's a little bit more comfortable. it has to be sampled first, but really it's very difficult to sample it because it cannot see fibs and positive sharp waves. Very rarely am I able to find fibrillations of positive sharp waves because the tongue is always moving. There's a lot of voluntary movement. Even fasciculation potentials can be very difficult to assess. But you must start with the genioclasis because the yield is still quite high. But there are studies now that have shown recently that if you increase the muscles that you sample, so along with genioclasis, do the masseter here, frontalis, for example, mentalis, for example, they can increase the yield a little bit, but otherwise it's very difficult to look for active denervation changes in the bulbar muscles. And without active denervation changes, you cannot label the muscle as abnormal. And remember, if fasciculation potentials are present, it must be associated with neurogenic changes. So limb onset, most involved limb to be tested, but first, obviously, start with the distal muscles and then go proximal. If that particular involved limb is abnormal, go to the opposite so-called normal limb. And if you can find denervation in the normal limb, in the normal means in the subclinical limb, then you're probably looking at motor neuron disease, and you will need to assess further at different segmental levels. So once you have shown that there's denervation in one segment, go to the next segment. So we've shown denervation cervical, go up to bulbar, go down to thoracic. So you have to keep moving. And sometimes you have to do lumbosacral anyway, even if thoracic is normal. So which muscles do you select? Distal more than proximal, your yield is higher. So this is quite useful, this sort of study that they did in muscle nerve, published in Muscle Nerve. So the distal muscles, that is your abductor pollicis brevis, your thenar muscles, first dorsal interosseous, and EDM as well. All three have a high yield, both in bulbar onset as well as upper extremity limb onset, both in revised LS Coriel as well as Awaji schema criteria. In the lower limbs, the distal muscles, tibialis anterior or flexor digitorum longus or tibialis posterior or medial gastrocnemius, all these muscles have a higher yield if it's a lower extremity onset. So these muscles have a higher yield compared to the more proximal muscles. So go for the distal muscles first and then move to the proximal muscles. Mid-thoracic, paraspinal muscles for both bulbar and upper extremity onset. So for lower extremity onset, once you have proven that there is diffuse denervation in both lower limbs, go to the lower thoracic paraspinal muscles first. Don't go to mid-thoracic, lower thoracic paraspinals. That will give you a better yield. If you have shown denervation in cervical segments or in bulbar segments, in bulbar onset or upper extremity onset motor neuron disease, go to the mid-thoracic paraspinal muscles. So how we tend to do it in the past, we used to do multiple muscles, so many different muscles, but now it's very easy. Select a distal first, either in APB or FDI. APB is more painful, so FDI is better. Then go to a deltoid muscle, which is more proximal. And then if both are positive, that's it in that limb, go to the next limb. But if only deltoid is positive and the FDI is negative, then look for another distal muscle. So something in the distal forearm, extensor indicis proprius or extensor pollicis brevis. And if that is positive, again, it's over, game is over, you can stop. If that is negative, choose another distal muscle. So in this case, if the distal muscle is only positive and deltoid is negative, go for another more proximal muscle like pronator teres. If that is positive, then again, stop. If that is negative, go to biceps. It's quite useful to have a little algorithm like this. And same goes for lumbosacral muscles. Go for something distally and proximally, so quadriceps and medial gastrocnemius, and then based on what you find, keep changing it so that you keep on involving a distal and a proximal muscle. And you just need to do, if you can show a distal and proximal shows denervation, then that's all you need to do to show that there is diffuse denervation in that limb. You can move to the next segment. So key points in motor neuron disease: nerve conduction studies excludes treatable neuropathies. Proximal stimulation is important, particularly in low motor neuron syndromes, to exclude a demyelinating motor neuropathy. Just because you have sensory abnormalities does not exclude motor neuron disease. Look at the bigger picture, look at how the motor responses are affected compared to the sensory studies. Neuromuscular junction abnormalities, I did not talk about it so much. There's just one final talk on NMJ assessment, and there I'll show you, but you can have false positive NMJ tests like repetitive nerve stimulation studies in motor neuron disease. We know EMG is the most important study, and we are looking for active on chronic denervation. And remember, and I've told this multiple times, but fasciculation potentials are abnormal if accompanied by chronic denervation changes. So our last assessment, I know, I'm sorry, it's quite late, but I'll try and finish it quickly. So it's myopathy. So again, myopathy, normal sensory nerve action potentials. So sensory nerve action potentials tend to be normal in myopathic disorders unless there is a coexisting peripheral neuropathy or entrapment syndromes, the same sort of thing that you look for in motor neuron disease. Motor studies also tend to be normal in a myopathy. So motor conduction studies or motor amplitudes are reduced only in certain types of myopathy, like distal myopathies, because you test your distal muscles with the motor studies, while the rest of the myopathies can be quite proximal, or motor studies may be abnormal in very severe, generalized, raging polymyositis. So the polymyositis that is so bad that the patient comes in and almost immediately gets intubated. That kind of bad polymyositis cases, you can have a generalized reduction in motor amplitudes, and also in critical illness myopathy. And it happens in critical illness myopathy probably because there is an element of channelopathy going on there. EMG, again, just like radiculopathy and motor neuron disease, is your gold standard, is what you're trying to do. And you look for spontaneous, abnormal spontaneous activity. So as we discussed before, fibrillations, positive sharp waves, they indicate there's myonecrosis. So if it is an inherited neuropathy, it indicates muscular dystrophy. If it is an acquired acquired myopathy, it indicates inflammatory myopathy. Also complex repetitive discharges you might see, and myotonia you will see in a myotonic myopathy. Then you also see myopathic potentials as we described before. So this is a patient, 44-year-old lady, 5-year history of lower limb weakness without any sensory symptoms, probably right more than left. Sensory nerve conduction studies are normal. So normally when we say sensory nerve conduction studies are normal, we think preganglionic. So we should be prepared to see if it's preganglionic. Sorry. Sorry. Sorry, time limit, I think. So have a look at this patient. So with a bit of contraction. So there's weakness there in the lower limbs, weakness in dorsiflexion. And you can hear a lot of contraction going on there. You can hear in the background. And here, if you see, the amplitudes are reduced distally. And the EMG actually, interestingly, shows a myopathic process. So this is a patient with distal myopathy. And this is what the EMG showed. So there's a early recruitment of short duration, small amplitude motor units. So it was a distal myopathy case, lower limb more affected than upper limb. So though she presented with foot drop, it was a distal myopathy. And reduced motor amplitudes, hence you tend to see in distal myopathy patients or in chronic myopathies or very severe generalized polymyositis cases. So this is another patient with a typical Gottron's rash, dermatomyositis kind of patient. There was spontaneous activity for this patient because it's an inflammatory myopathy and short duration motor units. So this was a proximal myopathic process with myonecrosis. Motor amplitudes will be normal because it is quite an acute one and it's not very generalized, as in it was not very severe. So it was an inflammatory myopathy. So this is another patient who had a progressive proximal weakness. And if you see, the motor amplitudes were slightly on the reduced side. It's quite low actually for somebody, microvolts, for somebody who is in their 40s. And if you see the EMG, myotonic discharges, multiple myotonic discharges were seen with myopathic motor units. And this is what they sounded like. And the same thing here. with myopathic potentials there. So it was a myotonic myopathy and actually looked more like a myotonic dystrophy type 1, which is the most common inherited myopathy anyway. So this is another patient, actually turned out to be a case of inclusion body myositis, because you can see the distal wasting of the forearm flexors with wasting of the quadriceps, and this is your myopathic potentials. Okay, elderly man, myopathic potentials. Forearm flexors showed myopathic potentials, and quadriceps actually showed mixed neurogenic and myopathic potentials. But remember, recruitment will always be early. So recruitment is something that you can use to differentiate between the chronic myopathies and chronic neurogenic processes. This is another patient of mine who was referred to the ophthalm clinic for testing the ptosis, but referred then to us by the ophthalm doctors. And everything was normal for him. Repetitive nerve stimulation studies were normal. Jitter studies were normal. Everything. EMG was normal, including of the muscles. And he turned out to have mitochondrial mutation. So normal EMG, so you can have normal EMG in myopathies, especially if it's steroid myopathy, because EMG looks at type 1 fiber, the fast twitch fibers, while steroids affect type 2 fibers, mitochondrial myopathy, congenital myopathy, and certain types of acquired and inherited metabolic myopathy as listed here. These can all give you normal EMG studies, but doesn't mean it's not a myopathy. So these are the quick things that you, so exclude neuromuscular conditions. That's what you have to do. Make sure it's not a motor neuron disease or motor neuropathies, because it's predominantly motor. And then make sure that you can show a myopathy, but EMG may be normal in some cases, as we saw before. Characterize a myopathy. Is it proximal? Is it distal? Is it symmetrical, asymmetrical? And finally, try and select a muscle for biopsy. So motor neuron disease, because reduced CMAP amplitudes will be seen in all these conditions. So it's important to know by putting the needle in whether it's a neurogenic cause for reduced motor amplitudes or a myopathic cause. Clinically weak muscles must be sampled, and thoracic paraspinal muscles are quite useful proximal muscles for myopathies as well. And remember, chronic myopathy can have neurogenic and myopathic potentials, but recruitment will always be early. So just my last slide, just how you approach the EMG examination. Just make sure you have a very clear clinical hypothesis, at least one provisional diagnosis and 2 or 3 possibilities which must be explored and confirmed or refuted. Make sure nerve conduction studies interpreted first after seeing the patient clinically with an electroclinical hypothesis ready before the EMG. Make sure patient is prepared. Start with the clinically affected muscle first. Try and select muscles which cause minimal pain, and look for relative contraindications like platelets less than 50,000, INR less than 2.5 in limbs or less than 2 in bulbar muscles. Next time, we'll quickly go through evaluation of neuromuscular junction disorders, facial motor conduction studies, blink reflex, and quickly look at electrodiagnostic evaluation of channelopathies. Sorry, I really overrun this time, but any time for questions or probably not, isn't it?
Excellent talk. Really taken a lot of pain collecting all the cases. Starting from basics, you have provided all the conditions. It was very, very useful. Unfortunately, the time limit for the link is only 2 hours, so
yeah,
I don't think we can take any questions at the moment. But
yes,
we'll see in YouTube channel there will be comments and questions, and you can try to clarify it.
Okay. Yeah, I'm sorry about the EMG sounds not being so clear. I can just see the things. I'm sorry about that.
Yes.
At least I hope they heard the myotonic discharges. I hope so. Anyway, okay, thank you.
There is one question you can answer that. Are you able to see in the chat section?
Yeah, so I think most of it was because
so primary muscle disease. What does it mean?
Sorry, where is that?
Sometimes in the reports,
you
see reported as EMG service for primary muscle disease. What does it mean?
EMG is
reported as primary muscle disease. Okay,
so I think probably they mean that it's a myopathy, that there are no neurogenic abnormalities, and the muscle is when you did the EMG, the muscle showed myopathic potentials. That would probably mean that it's a primary myopathic disorder. Whether it's acquired, inherited, probably difficult to say on EMG. I think that's what that would mean.
Thank you once again. This is a great talk. A lot of nice videos.
Thank you.
Just very, very useful. Thank you.
Thank you. Thanks, everyone. Thank you.
We can stop recording.